the introduction, ma'am.
Yeah.
Yeah. Good evening, esteemed faculty members and all the delegates. Thank you for joining. Today we are back with our series, A Dynamic Dialogue on Fertility, episode 37. And today's topic is Aphrodite Criteria, organized by Foxy Society and A4 Hospitals and Fertility Center, Chennai. So it's my privilege to introduce the moderator of today's webinar, Dr. Arun Kumar, sir. Sir is a consultant urologist at RG Stone Urology and Laparoscopy Hospital, Chennai, and also consultant andrologist at A4 Fertility Hospital, Chennai. Sir was speaker and chaired sessions at various national and state urology conferences. Sir has four publications and a book chapter on holmium laser prostatectomy. I welcome you, sir. And I request you to please introduce Dr. Reshmi.
Yeah, Dr. Reshmi done her MBBS from Maher, Meenakshi Academy of Higher Education Research, MSOG from Balaji Vidyapeeth, and she's a postdoctorate fellow in endogynecology under the Tamil Nadu Dr. MGR Medical University, and presently pursuing her fellowship in reproductive medicine at A4 Hospital. She's a very young, dynamic, and very inquisitive person. Asked a lot of questions, and I think she has analyzed this paper very thoroughly for all of us to benefit.
Thank you, sir. I'll share my screen. Good evening, everyone. Today I'm going to talk about Aphrodite criteria. Subfertility as such is estimated to affect about 187 million couples worldwide. Overall, in the reproductive age group, it is seen to be affecting 1 in 6 couples. And male factor alone is seen in 50% of these cases, and it is a sole contributory factor in 20% of these cases. In most of the cases, the cause is idiopathic. And because many men facing infertility issues do not seek medical assistance even in developed countries, there is underestimation of its global impact. The Aphrodite criteria was first published in RBMO in 2024 by Estivus et al. It was a novel way of classifying hypogonadism or testicular function and seeing different ways in which hormonal therapy could benefit it. The research question is, can a novel classification for the infertile male, by classifying them into different groups, help in design clinical trials on the hormonal treatment for male infertility and treat endocrine imbalances? This was a collaboration between andrologist, reproductive urologist, and ART specialists based on clinical descriptions and laboratory testing. The target population is infertile males who could benefit from hormonal therapy to improve sperm quality and quantity for both NC cycles as well as ART treatment. The key parameters that were taken into consideration for this classification are your conventional semen analysis, serum FSH, and serum testosterone levels. Prior to doing hormonal analysis, it is imperative that we look into the clinical parameters, clinical history, medical history, surgical history, onset of puberty, sex life, lifestyle factors, and medication use. General examination of the body composition, obesity, signs of virilization and hypoandrogenism, and examination of scrotal content. According to the article, semen analysis parameters are taken as per WHO 2021 guidelines, the 6th edition, and abnormal values are considered less than 5th percentile of the normal parameters. What is the role of endocrine pathways in male infertility? The FSH acts as the first step of spermatogenesis. FSH acts on the FSH receptor in the Sertoli cells in the seminiferous tubules of the testis, helping in spermatogonial maturation. The LH acts along with the LH-HCG receptor in the Leydig cells, resulting in the production of testosterone. So this LH and LH-dependent ITT and FSH act on sperm maturation. The concentration of ITT is seen up to 100 times higher than the serum total testosterone concentration. However, it is very impractical to measure ITT because it is very invasive procedure. The hormonal workup, therefore, will rely on FSH assessment and total serum testosterone levels, which will act as proxy for ITT. FSH as seen as a marker of spermatogonial function. As per study consensus, the normal values are taken as FSH between 1.3 to 8.4 international units per liter and LH 1.6 to 8. For all practical purposes, any value less than 8 is considered as lower limit of normal. The serum testosterone levels are measured in the morning fasting blood sample. The commonly used threshold is 320 nanogram per deciliter. And this circulating testosterone concentration is helpful in determining whether the HCG therapy is working or not. Along with this, in 2017, Emery et al. Published a paper where serum 17-hydroxyprogesterone could be used as a potential biomarker for ITT as well as hypogonadism, and it is also used for helping assess the response to medical therapy. What is the link between hypogonadism and infertility? We all know about idiopathic causes, we all know about genetic factors. The others, hormonal disorders, genetic tract infection, chronic disease, varicocele, febrile illness, viral illness, cancer treatment, any history of gonadotoxic drugs, all these are seen to cause hypogonadism, leading to reduced spermatogenesis. The rationale behind stratifying into 5 groups is based on the fact that both FSH and ITT are required for quantitative and qualitatively normal spermatogenesis, and any deficit in these can affect the spermatogenesis. So based on this, there are 5 groups. Group 1 would be hypogonadotropic hypogonadism, that is acquired and congenital. Group 2 would be your idiopathic, that is lowered analysis parameters, but FSH and testosterone levels are normal. Group 3 is a variation of group 2. The semen parameters are lowered, testosterone levels are lowered, but FSH will be normal. And group 4 is hypergonadotropic hypogonadism. Group 5 is unexplained male infertility in the context of unexplained couple infertility. Coming to group 1, this is hypogonadotropic hypogonadism. There is gonadal failure, there is reduced gametogenesis and reduced steroidal production. So all your hormones are reduced and your semen analysis parameters are reduced. This accounts for about 1.9% of azoospermic male patients and 1.6% of male subfertility cases. We have 2 forms. We have congenital and acquired. In congenital, we have anosmic hypo-hypo and normosmic hypo-hypo. Anosmic is when there is defective migration of GnRH producing neurons, and normosmic is where there is isolated hypothalamic deficiency. With acquired forms, we have external factors that could either affect the hypothalamus or pituitary. We have drugs, infections, tumors, hyperprolactinemia, any irradiation, gonadotoxic drugs, and lifestyle factors. Management would be GnRH pumps or exogenous gonadotropin containing LH activity. Hypo-hypo patients, when given exogenous gonadotropins, the pregnancy rates are seen up to 78%. This is one of the first group, is an exemplary example of how gonadotropins can reverse your male fertility status. HCG is started between 1,000 to 2,500 international units. This is given twice a week for up to 12 weeks. This 12 weeks is very critical to increase your testosterone concentration. For adult onset hypo-hypo, we can give HCG. If it is congenital, it is imperative that we include FSH 150 to 300 international units twice or thrice a week for up to 18 months. With combination therapy, the sperm count is seen to be higher than monotherapy. In patients who are responsive, we should counsel for cryopreservation. Aphrodite group 2 is idiopathic male subfertility. It constitutes a large chunk, 15 to 60%. These are NOA patients who have normal hormone parameters. However, this hypogonadism is relative. That is, even though we have normal hormone parameters, they are functionally insufficient to support normal spermatogenesis. And hence, in such patients, FSH monotherapy could be helpful. What is the real-world data on the role of FSH? This was a study done in Italy. This was published in 2022. It was a single-center retrospective study over the past 7 years. Out of 362 patients who had abnormal semen parameters, 156 patients were given FSH and evaluated. The mean duration of therapy was up to 9 months. At the time of publication of the paper, 43 pregnancies were recorded, 22 natural conceptions, and 21 with ART. And the male partners of couples who achieve pregnancy have seen to have increased sperm concentration and progressive sperm motility. Meta-analysis on FSH treatment in idiopathic infertility has shown 15 control studies, 600 men who were given FSH, and The pregnancy rates, sperm parameters, and testicular volume was evaluated, and it was seen to have a notable improvement. Both your recombinant as well as purified FSH have a similar efficacy. However, the number needed to treat is very high. For achieving one clinical pregnancy, you need to treat up to 18 male patients. Aphrodite group 3 is a variation of group 2. However, as per your ICMRT definition of hypogonadotropic hypogonadism, this can also be considered as a variation of group 1 because this is reduced gonadal steroid production that is secondary to gonadotropin production as or action. So your production will come under group 1 and your action will come under group 3. So when we are giving FSH, whether the response is there, how good the response is, it depends on the genetic background. We have two common types of genetic changes that could happen. One is your FSH receptor polymorphism, and another is single nucleotide variation in FSH beta subunit. Of this, the polymorphism in FSH beta subunit is most responsive to FSH exogenous hormones. With FSH receptor polymorphism, there is modulation in the Sertoli cells. Therefore, there is decreased sensitivity to FSH. Nevertheless, there is some degree of improvement in semen quality. With FSH beta subunit, when we are giving exogenous gonadotropins, there is also seen to be decreased DNA fragmentation index. Because testosterone is essential for spermatogenesis, the reduced levels indicate that there could be reduced LH activity. So, there is role in giving both LH and FSH therapy. Patients who have non-obstructive azoospermia secondary to hypospermatogenesis or maturation arrest, after giving hormone therapy, there is seen to be higher sperm retrieval rate. The most common drug regimens would be combination of HCG and FSH 2 to 3 times a week, up to 3 months or longer. So we start with recombinant FSH 150 units twice a week, and we look at the semen parameters and the hormones up to 3 to 4 months later. If there is improvement, then we proceed with natural cycle. If there is no improvement, then we'll have to go for ART. If there is improvement, but the testosterone levels are below reference range, then we will have to consider adding HCG 1000 to 2000 subcutaneous. With Aphrodite group 4, this is hypergonadotropic hypogonadism. So there is inadequacy in stimulating Sertoli and Leydig cells, or it could be a Leydig cell insufficiency. In these patients, giving exogenous gonadotropins may stimulate gonadal cells, resulting in stimulus for proliferation. With NOA patients in Klinefelter syndrome, it has been seen that after giving them hormonal therapy for about 3 months, testosterone concentration increased, thereby increasing the successful sperm retrieval rates. So we start with HCG, 1000 to 2000 international units. We monitor FSH, LH, testosterone, and E2 levels every month. And we aim to keep the testosterone target greater than 350 nanogram per deciliter. And accordingly, we adjust the HCG dose. With HCG injections, there could be a decrease in FSH levels. If it goes less than 1.5 international units, then we add recombinant FSH, 150 international units, twice a week. And we can also add anastrozole if the T by E2 ratio comes less than 10. And we do monthly assessments. If we are able to get a viable sperm in the ejaculate, we will freeze them. If it's persistent azoospermia, then we go for microsurgical techniques. The sperm retrieval rates with non-obstructive azoospermia are seen with the plain testicular aspiration up to 40%, conventional extraction up to 50%, and with microdissection up to 70%. A study, an article that was published in Fertility and Sterility in 2021, it asked about 10 questions in each of the segments, that is male infertility, female, ART, techniques, and ethics. And in male infertility, the 5th question, can we improve surgical sperm extraction outcomes using endocrine stimulation protocols? Probably Aphrodite criteria could answer that question. Aphrodite group 5. This is unexplained male infertility, where there is normal FSH value, normal testosterone, normal semen parameters. There is no history of any disease. Physical examination is normal. Laboratory testing, genetic analysis, all are normal. And there is no role for individual treatment. There could be a role for FSH monotherapy. Those studies are still away. What is the evidence is that spermatogenesis does not operate at its maximum capacity. So when we give supraphysiological levels of FSH, it could improve your sperm quantity and quality. In primates, when we do hemicastration, there is compensatory volume increase on the other testes. And men who are having FSH secreting pituitary adenoma, there is also seen to be increased testicular volume. So this could pave way for hormonal therapy, FSH monotherapy in unexplained infertility. The current guidelines only consider semen quality as the first and primary marker for male infertility. The other investigations, they are still not done routinely. And so according to this criteria, along with clinical examination and patient description, along with semen analysis, if we could also do hormonal evaluation, then we'll have a bigger framework for decision-making and future research trials. When we are giving hormonal therapy for one cycle, that is 3 months, this can help in deciding if we should continue this for another cycle or it is enough to start ART. And also in patients who are oligospermic, we can convert these patients from an ICSI treatment to an IUI or an NC cycle. The limitations are that we do not know the safety of supraphysiological FSH that are given in males. And for all practical purposes, the studies show give up to 3 months, that would be one cycle. But what is the dosing? What is the duration of gonadotropins is not yet given. There's a lot of heterogeneity of the trials and studies. So we can see that Aphrodite criteria is seen to be a standardized approach to male infertility. There is a collaboration between andrologists, urologists, and ART experts. However, there's a lot of area that lack data, and there is increased scope for clinical research in future. A summary of all the 5 groups with their treatment is in the slide. Thank you. Hello, sir.
Hello.
Sir.
Yes, got a good content. Maybe we should have been little slower with these slides. What happens? Something new is being told, no? So sometimes we cannot drive that fast. So it's okay, but anyway, the point is we are doing the hormonal evaluation in all patients with count below 10 million. And these patterns, although they are defined now as a part of the criteria, somebody has taken the pain to do this study and publish it. We generally see these patterns on a routine basis in our subfertility patients. So we do have this hypogonadism, and then patients with normal FSH-LH but low testosterone, and then patients with low FSH, low LH, testosterone is also low, and then you have count SO80 or nasospermia. I'm not talking the hypo. So hypo is a different picture. There are other adult people with low hormones, low gonadotropins, and low testosterone. And then you have people with low gonadotropin, normal testosterone also. So many permutation combinations we do see, but it is very nice to put them into some categorizations so that we can choose the appropriate regimes or treatments or may benefit. Sort of study present. We need more patient and we have to sometimes correlate biopsy findings or the parameters in the testis also, tissue parameters in the testis. Because as of date, there is no way to predict which, although we say the medicines or injections can be given in various criteria, still the response rates are not very uniform. Each patient responds in a different manner. So I would be more interested in having a clinical correlate, like if the patient has all these parameters and is being taken up for a micro TSA or a TISA, we always like to assess the tissue, testicular tissue. So suppose there are 3-4 patterns we have: hypospermatogenesis, maturation arrest, and then Sertoli only syndrome, early and late maturation. So 4 patterns are there. So among these 4 patterns, if there is a correlate that the hormone may work in certain patterns, then it is better to sort of filter further and give the medicines only to those individuals who may have a higher chance of response, because sometimes it just keeps prolonging the time the patients generally take to decide for the treatment. But nevertheless, a 3-month course is definitely warranted, and AUA guide.
Sir, sir, excuse me, sir.
Yeah,
Sir, your voice is not very audible, sir.
you are able to hear me now.
Yes, sir. Now better, sir.
No, better. Probably there is an air conditioner running.
You can maybe you can switch off the video for better signal, no? The signal is little bit breaking in between.
Okay, I switched off the
Yeah.
video.
Yes.
Yes. So basically, we need to have a clinical correlate. Apart from the hormonal parameters, we also like to see the biopsy patterns. And in patients with particular biopsy patterns, if there is a better response, then we must consider sometimes doing a FNA also pre-operatively before starting with the injections on what particular testicular pattern they may have. This is something for the future and sort of an inquisitive area where it may be a important development that will help to choose the correct patient who will be responding to the treatment. But otherwise, the AUA guidelines, EAU guidelines, all of them accept usage of FSH, but it is not a high grade recommendation. It's a grade B or a level 2 recommendation only that they generally give for usage of FSH that is in patients with idiopathic infertility. They are telling the Aphrodite 5 criteria. So the idiopathic infertility with the FSH normal, sometimes they say you can stimulate them with the FSH and see. So nevertheless, the ball is sort of the judgment is still not out, and our results will probably become more versatile, better as we keep using these injections and also monitoring what happens to the patient when he takes these injections. Yeah.
Um, Actually, whenever I read this criteria, we have lots of doubts and confusion about this criteria. The thing is, everything looks, except for the first group and the fourth group. First group is hypo, and the fourth group is hyper. So it's a testicular failure. And at least the third group, we can see that it's a polymorphism. We really get confused with the group 2 and group 4. How we can differentiate 5, group 2 and group 5? How we can differentiate, and what is that they are meaning by this?
See, basically, they are trying to suggest that we give FSH, like how you're doing the ovarian stimulation, testicular stimulation for almost all categories. So, if you look at the summary slides, it will be written that there will be HCG almost for all the 5 categories and FSH for 3 out of the 5 mostly. So, basically, it's like you can give FSH in almost all patients. The point is, give FSH only if it is, say, a normal value in the patient and he has low counts and testosterone seems good. In that category, that is the idiopathic category, that you can consider. Another category is the difference between the two is the testosterone value. They have a low testosterone but a normal FSH. So that again, sometimes you can stimulate with both HCG and FSH. So that is the basic difference. So look at testosterone, look at FSH, and then you decide.
Sir, so how does AMH in male correlate with this, sir? Does it have any role? He's not here, no? Rashmi ki ticket. She is also here. Oh, sorry, I missed it. Also we are all here together, but just to interact, we all are here, three of us here.
Yeah.
So we couldn't hear you in between. I think Nitya asked a doubt.
Yes.
Yeah.
See the.
Sir, yes, sir.
Yeah. Go ahead. Tell me.
Sir, does AMH have a role in male fertility, sir?
AMH nowadays they are suggesting as a promising marker. Like previously, we used to do inhibin B as a marker of the function, Sertoli cell function. So similarly, this AMH again becomes a marker of the testicular function, supporting cells basically. So when you have higher levels, like normal levels, it is different. Low levels means there may be difficulty sometimes in retrieving the spermatozoa. Inhibin also had the predictive value whether you can get sperms during the micro-TC or not. That's the main role of the inhibin B. And sometimes we also nowadays have some patients who do it the test outside and come. And if very poor values, then most likely the retrieval is going to be difficult. Generally, we had cut off below 80 inhibin B, we will not get sperms. So up to 150 is okay. More than that is all fine. So below 80 patients will be difficult to manage. But these are all, again, on a case basis. Our fertility problem with fertility is each patient has to be managed as a single individual, cannot put all the guidelines into the same patient. And sometimes they may have all the factors not going for them, but yet they may be able to retrieve sperm. So there are many not understood factors also there. But predominantly, look at the FSH and testosterone. 2 points that we can mainly manage is look at the FSH and look at the testosterone. Mainly, be sure that he is not on any previous medications which may alter either of these. Sometimes the patient has taken clomiphene for some time, he will have FSH 8. We had a patient in the last OPD, we were discussing with Dr. Rashmi also, that the patient, again, we checked again, it became low. So basically, it is a low FSH. Because of the medicine, it became high in between and then it came down again. And the patient also had a low testosterone, this category of low FSH, low LH, and low testosterone. So this is very common, and hormonal manipulation is very useful because we are getting more and more subfertility is primarily hormonally imbalanced subfertility only. As like you get in females, even males, the obesity and the peripheral fat, aromatase activity. So all these play a significant role, stress and stress-related variations in the hormones and the autocrine factors play a role in the subfertility.
Sir, is there any other markers to test the intra-testicular testosterone levels, sir? Anything else that we can, other than 17 OHP, is there anything else recent, sir?
Nothing. I don't think that we don't have any intratesticular testosterone levels are not measured generally. Maybe something on the research, but I do not know. Clinically, we are not able to measure anything. The 17-hydroxyprogesterone is also, it indicates the steroidal biosynthesis pathways are going on, and you don't have a very high value or a very low value indicating deficiency in the steroidal biosynthesis pathway. But other than that, that does not correlate also. You will get a low testosterone and a 17-OH may be normal. So it does not match.
Cutoff, sir, for
17 hydroxy is 0.5. Below 0.5, you can give again these injections, hormonal stimulation, and see if there is a response.
Okay, thank you, sir.
Yeah.
Sir, what is the role for estrogen modulators? Only in one group they had given estrogen receptor modulators.
Estrogen receptor modulator is not approved.
Okay, sir.
We cannot give. Yeah, we are giving clomiphene many times, selective estrogen receptor modulators, but they are not prescribed in any guideline, in any form.
Okay, sir.
Only role for the other function is the aromatase inhibitors, which they say the testosterone estradiol ratio variations you can give. And very low level of recommendation for the clomiphene, but aromatase inhibitors has a grade B recommendation.
Okay.
Yeah, good. Thank you. Thank you for this presentation, Dr. Rishmi and Dr. Arun. I think we got an overall idea, and there had been there is observership and there is perceptorship and there is a conference happening for Aphrodite Criteria. So I think European doctors are doing lots of effort on this. So they are having one workshop for Aphrodite Criteria. I really wonder what they are trying to tell us, that everybody has to be put on FSH, then it'll be improving or not. Usually, they are not people who give like this evidence. They are very critical about giving anything for as a supplementary drug because the insurance companies have to sponsor it in abroad. But how they are able to come out with this criteria, so that I think if a criteria is supporting the use, then the insurance company should sponsor this abroad. So we will see. We will use it. Maybe as a team, we should use it for patients. Uh, can we? The question why we brought this for the forum is, can we separate the patients who have low weight, that is OAT and SOAT and azoospermia? Yesterday we had a first quarter review meeting. So in that we had a discussion on male fertility clinics, and we wanted how to improve that. Maybe all the patients who are having a low, less than 10 million counts, can we make them into this Aphrodite criteria classification? Because we're doing all the tests. We are doing total testosterone, we are doing FSH and everything. So once this category has been put and our intervention, whether it is improving or not, if we are able to do a study and analyze for ourselves, whether it is useful for publication or not, it will be useful for our patients. So that's what the ultimate aim of doing this presentation today. So I think we as a team should, any patient less than 10 million, we should see which Aphrodite criteria this patient is fixing in. So maybe AC, we can put AC. If Aphrodite is a very attractive name. So maybe AC1, AC2, we will categorize. And Dr. Anbarasan, Dinesh and Gokul are helping us to make this Excel. Once they make an Excel and categorize, all the centers can put in their data through the andrology, because anywhere they're going to do a semen analysis with us and the blood test is done with us. So easy to capture the data. If you're going to have at least 50 patients per month, and we are going to have a data at the end of a year, we'll be having a fantastic data for us to understand this criteria better. We are actually doing gene andro panel, which is actually adding confusion, but we are able to answer the patients who are actually having a doubt, whether why my sperms are low and how it can become low. I'm a teetotaler, I'm an expert, I'm a very perfect weight, I take good diet, I'm a very good person by heart, but my sperms are less. So these expressions are being given by the gene andro panel that we do, and we feel that it is giving us FSH receptor mutations, and they are giving so many other mutations. For females, when we had empty follicle syndrome and fertilization failure, I had a patient with TUB gene mutation, PI gene mutation, which I've read in the books. So at least that tells me that I need not do another time IVF for that patient, because there is a mutation in the maturation defect is there. This patient will always get a immature or empty follicle syndrome. So moving ahead, when a world is creating a criteria, they would have not created a criteria just because they want to create one. There should have been a need for doing it. So we will try to at least adopt the criteria in our system and see how that is useful or not. I think after a year, if we are going to have a discussion again on this, we should talk with our data. Yes, that should be helpful, I think.
Yes,
Yeah.
another thing we already have, we have been using all these injections so far also.
Yes.
And even the
Yes,
data of patients who are on these injections will be there in our system.
Yeah, that's also a good idea. We will have retrospective data also. Reshmi can only analyze that. Definitely, we'll have retrospective data. Good idea.
For the last
Definitely.
1 year, you can have, we can at least have a point of response. What happened to his, outcomes, fertility outcomes. That at least you can record. Sometimes semen analysis, you will have SOAT only. But the hormonal picture, if you are able to not get, at least those patients on the injection, basically, whether they have low gonadotrophin, high gonadotrophin, what category they fit into, at least instead of the 5, you can simplify it and probably make it 3 or 4 also, it is okay. So
Yes.
that is also another option.
Only thing which we would have not done is they are asking to recheck the value. Very rarely we recheck the value. We are very fast though, so we start the treatment. Maybe baseline is anyway there. We will see what has happened to them. We can definitely see this. It's a useful one. UISR is coming. You can do this and present in UISR. And one more thing, UISR to our team. UISR is releasing the scientific brochure. There is paper and poster presentation. It is a national conference which is happening in Chennai. It's very easy. It is in Green Park. So people can just walk and have a national publication, paper poster publication. And Sindhuja, embryologist, is responsible for paper poster. Any doubts, you can also call personally because our own team from Chennai, we are doing it. I'm there, a part of TAPISA, and Nitya is there. So our team, I think at least 4 or 5 presentations we are looking at. So when you wanted these, if after presenting, you can also publish it. With little bit modification of the data, you can also publish in a journal. So come forward for, it's already late. It's going to happen on June 13, 14, 15, just a month apart. Just 1 month is there. So kindly come forward. It's a national conference on reproductive medicine. So utilize this. Thank you. Yes.
Thank you.
Yeah.
Yeah.
Thank you.
Yeah, bye.
Thank
Thank
you.